Welcome to This Explainer. Today, we're diving straight into forensic medicine, unlocking what experts call the mind's vault to explore the intense and often surprising world of craniocerebral trauma.
We're going to use the fascinating intersection of forensic pathology and pure physics to solve a fatal medical mystery. We'll start our investigation with a truly terrifying phenomenon known in emergency rooms as the talk and die syndrome. So, picture this. You have a heated bar fight. A young man takes a single hard punch to the jaw. He falls completely backward and strikes the back of his head right on the hard floor. He's knocked out cold, but only for about 2 minutes. To everyone's immense relief, he wakes up, brushes himself off, and vehemently refuses to go to the hospital, claiming he feels absolutely fine. He walks home, has a glass of water, and goes to sleep. But the next morning, his roommate finds him dead in his bed.
Okay, so let's break down the exact timeline of that fatal night. The guy who threw the punch is understandably terrified. He insists over and over that he never meant to kill him. During the autopsy, the forensic pathologist does find a linear fracture on the back of the skull, right where the victim's head hit the floor. But here is the bizarre twist. The massive, fatal brain contusion, it's located at the very front of the brain, completely isolated in the frontal lobe. To figure out how this seemingly impossible sequence occurred, we have to look really closely at the underlying anatomy. To gather our clues and piece this puzzle together, we literally have to dissect the architecture of head trauma layer by layer, from the outside in. We'll look at the scalp, the skull, the meninges, and finally, the deep brain tissue itself. Clue number 1 lies right on the surface, the scalp. Now, the scalp is incredibly vascular, which means even a really minor cut is going to result in profuse, terrifying bleeding. But the scalp also creates this wild phenomenon we call the forensic illusion. When the scalp gets struck by a blunt object, say a heavy stick, the skin stretches so tightly over the bone that it actually splits in a remarkably straight line. This is a split laceration, and it heavily mimics a clean, incised wound made by a knife. To avoid getting totally tricked by this illusion, investigators have to look incredibly closely inside the wound for crushed hair bulbs and intact bridging tissues just to confirm it was actually blunt force trauma and not a blade. Moving one layer deeper to the skull, fractures actually act as an almost literal signature of the weapon used. A fissured or linear fracture is a simple crack, usually from falling against a broad, flat surface. A depressed fracture happens when you're struck by a heavy weapon over a small area, and it perfectly replicates the shape of whatever hit you. Then there's the pond fracture, which is this flexible, ping-pong ball-like dent that you exclusively see in the soft, pliable skulls of infants. And a ring or hinge fracture at the base of the skull, that violently occurs if someone falls from a height and lands squarely on their feet, driving the spine right up into the skull. Now, in our victim's case, the autopsy revealed a linear fracture at the back of the head, which is completely consistent with a simple fall to a flat floor. Now, this is absolutely crucial. There is a stark contrast between the types of bleeding that can happen in the meninges. An extradural or epidural hemorrhage is a high-pressure arterial bleed. It almost always involves tearing the middle meningeal artery and is strongly associated with skull fractures, typically in young adults. On the flip side, you have a subdural hemorrhage. That's a low-pressure venous bleed caused by tearing those delicate bridging veins, and we most commonly see this in the elderly and in chronic alcoholics. To really get why subdural hemorrhages hit the older population so frequently, we just have to look at the brain's natural aging process. Advanced age or chronic alcohol abuse causes severe brain atrophy. The brain literally shrinks. And as it pulls away from the inside of the skull, those tiny bridging veins get pulled incredibly tight. They become so stretched out that even a trivial trauma, like a minor stumble or sometimes just shaking the head too violently, can snap them. Because it's a low-pressure venous leak, this lethal hematoma can develop super slowly over weeks. So bringing it back to our bar fight mystery, the linchpin here is a phenomenon called the lucid interval. This is the classic hallmark of an extradural hemorrhage. Our victim suffered a brief concussion, woke up, and was perfectly alert, right? But during this period of completely normal consciousness, that torn middle meningeal artery was silently pumping high-pressure arterial blood into the incredibly tight space inside his skull. This creates a terrifying false alibi. Everyone around him assumes he's perfectly fine, but an expanding hematoma is in there ticking like a time bomb, until it eventually crushes the brain, causing a sudden coma and death. Getting down into the deep brain tissue, we also have to distinguish between a functional injury and a structural one. The victim's initial 2-minute knockout, that was a concussion. A concussion is purely functional. If you take a CT scan of a concussed brain, it will look perfectly normal, even if the patient is dealing with memory loss. But what actually killed our victim was a contusion. A contusion is a structural injury. It's a literal physical bruising of the brain tissue itself, characterized by real bleeding and cellular necrosis.
Let's fast forward a bit and modernize our toolkit, because the 2026 forensic and clinical standards have evolved massively. We know now that lethal brain injuries don't always show up as these massive, obvious contusions on a standard CT scan. High-speed rotational forces can cause a diffuse axonal injury, which basically tears microscopic axons all across the brain. Today, you absolutely need advanced diffusion tensor imaging MRIs to spot these tiny neural tears. Plus, ears don't just sit around waiting for a patient to clinically deteriorate anymore. They immediately test for specific traumatic brain injury blood biomarkers like S100B, UCHL1, and GFAP. Spikes in these levels confirm instant brain cell destruction right after the trauma, allowing doctors to rush in with emergency surgery before it's too late.
All right, let's pivot to the literal physics of impact to find our final and honestly most important clue. The exact location of a brain contusion tells us precisely how the injury went down. We start with a coup injury. If a stationary head gets struck by a moving object, let's say taking a baseball bat to the head, the brain contusion is going to happen directly beneath the point of impact on the skull. But what if a moving head strikes a stationary object, like our falling victim hitting the floor? Well, the physics completely flip. The skull suddenly stops dead against the floor, but the brain inside, it keeps moving. It rebounds right through the cerebral spinal fluid and smashes into the skull on the exact opposite side. We call this a contra-coup injury, and the resulting contusion forms completely opposite to the point of external impact. Here's the absolute best way to visualize this. Just think of your brain like an egg. The brain itself is the yolk, the cerebrospinal fluid is the egg white, and the skull is the shell. If you smack a stationary egg with a spoon, that's a coup injury. The yolk breaks right where the spoon hit. But if you throw that egg against a wall, that's our contra-coup injury. The front of the shell hits the wall and stops instantly, but momentum carries that yolk right on forward, violently smashing it against the front of the shell from the inside. Zooming out for just a second before we take all these clues into the courtroom, I want you to keep a few other classic physical hallmarks in mind. Severe bruising behind the ear, which we call battle sign, or bilateral bruising all around the eyes, known as raccoon eyes, are definitive red flag indicators of severe base of skull fractures. And in pediatrics, if you see bilateral subdural hemorrhages paired with retinal hemorrhages and there's no history of a massive car crash or something similar, that is the absolute clinical hallmark of shaken baby syndrome, pointing directly to severe child abuse. So, transitioning from the cold stainless steel of the autopsy table straight into the high stakes of a courtroom, the defense attorney inevitably stands up and asks the ultimate medical legal question about premeditation. They look right at the pathologist and ask, did my client intend to kill the victim with that punch? So how exactly do we resolve this whole talk and die mystery? Well, the victim fell backward, suffered a linear fracture on the back of his head, and experienced that classic lucid interval where he was walking and talking just fine. But remember, the massive fatal blow was a contra-coup contusion sitting up in the frontal lobe, entirely opposite to the fracture. Because that massive brain contusion was a contra-coup injury, it's scientifically proved beyond a shadow of a doubt that the victim's moving head struck a stationary object. The unforgiving ground, not the direct force of the attacker's fist, is what caused the death. If the punch itself had been the lethal blow, we would have seen a coup injury right under the jaw strike zone. This hard scientific fact fully supported the attacker's claim of an accidental fatal fall, and it actually reduced the charge from premeditated murder down to manslaughter. Which brings us to the end of this investigation. It is wild to think about how the relentless laws of physics and these tiny microscopic anatomical details ultimately dictate the scales of justice. It leaves us with a pretty provocative question to chew on. If a simple slip of physics, just the difference between a coup and a contra-coup injury, can reduce a charge from premeditated murder to manslaughter, how many other major courtroom verdicts out there are currently hanging on nothing more than the microscopic stretching of a single vein?